So coming to the management, the non-pharmacological measures are equally important as pharmacological measures. Educating the patients about peak flow monitoring and monitoring their symptoms, avoidance of well-known triggers, smoking cessation, physical exercises and relaxation techniques go a long way in managing their asthma. These are the common drugs which are used for the treatment of asthma. So the commonly drugs which have known safety during pregnancy include the short-acting beta-2 agonists such as salbutamol, the inhaled corticosteroids such as budesonide and beclomethasone and fluticasone. When it comes to long-term beta-2 agonists, we have two of them, formoterol and salmeterol. Both are deemed to be safe. However, literature is more with salmeterol as compared to formoterol. When it comes to other drugs, the data is limited. However, in the animal studies and other human case reports, it has been deemed to be safe and can be used. So as a rule, if a patient has been on a drug pre-pregnancy, we never stop it or change it or de-escalate during pregnancy. We continue the entirely the same treatment in case she was on treatment before her pregnancy. Only drug to be used with extreme caution is methylxanthines, that is your theophylline, doxophylline, deriphyllins, etc. We have to monitor their serum levels to avoid toxicity, generally to be avoided in pregnancy if possible. So now coming to the stepwise management of asthma. So we all know the asthma management divided into steps. So initially, if your patient has symptoms rarely, few times a week, doesn't have nocturnal awakenings, her lung function is normal, then we can give as needed therapy. Nowadays, as needed therapy is supposed to be done with the AIR. That is, you have a reliever which has also anti-inflammatory action. That is, the reliever is ICS, that is inhaled corticosteroids, along with a long-acting beta-2 agonist, that is formoterol. For this category of patients, you give only as needed treatment. There is no requirement of a maintenance therapy. Coming to step 3, this includes patients who have symptoms on most days of the weeks, occasional nocturnal awakening, and may have slightly reduced lung function. For these cases, you start with regular maintenance and reliever therapy. This is called as a SMART therapy, that is single maintenance and reliever therapy. The same drug combination, that is formoterol plus inhaled corticosteroid, is used as a maintenance therapy twice a day plus as a reliever whenever the patient has an increase in the symptoms. Now coming to step 4. So these are the patients who have symptoms on most days of the week. They have frequent nocturnal awakenings. They have multiple asthma exacerbations, or patients who are requiring to use reliever medication multiple times in the day. For these patients, you use medium dose SMART therapy. So basically, you give the same inhaler at a higher dose. Now coming to the step 5, these are patients who remain uncontrolled despite medium dose inhalation therapy with inhaled corticosteroids and formoterol. For these patients, you can add other drugs like montelukast and LAMA, that is ipratropium, that's a long-acting muscarinic antagonist. These patients should also undergo what we call as phenotyping by assessing their blood eosinophil levels, serum IgE levels, probably a PFT which includes a pheno. And in case they are T2 high asthma, you have the option of biologics in pregnancy. So nowadays, asthma management is changing dramatically with these newer biologics available in the market. The first 3 are available in the Indian market as of now. Dupilumab will probably come by next year. Omalizumab, which is the anti-IgE antibody, has the maximum data. There is an expect registry which has shown that on pregnant people using omalizumab do not have increase in congenital anomalies, low birth weight, or small for gestational age. Mepolizumab, anti-IL-5 antibody, has shown no harm in animal studies. Currently, there is a registry going on. Data will be out in 2026. Bendalizumab and dupilumab also don't show any adverse signal in animal studies. So like any other asthmatic, a pregnant asthmatic is also prone for exacerbations. Exacerbations are common in the second trimester especially, and the risk factors for exacerbation are severe asthma, multiparity, black ethnicity, smokers, age more than 35 years, obesity, anxiety and depression. Addressing and managing these risk factors not only reduces the exacerbation, it also improves asthma control and leads to better perinatal outcomes. So management of asthma exacerbation very similar to a non-pregnant lady. However, the treatment needs to be done early and adequately to avoid maternal and subsequently fetal hypoxia. Oxygen therapy should be initiated early and a minimum SpO2 of 94% should be maintained throughout the stay in the hospital. Pharmacological management includes nebulized bronchodilators, IV or oral corticosteroids, IV magnesium, and antibiotics and antivirals if indicated. Surprisingly, 90% of the women with asthma tend not to have any symptoms during labor or delivery. It has been known that airway function improves significantly in the last 4 weeks of pregnancy, which may help in preventing symptoms of asthma during labor and delivery. Patients generally return to their original asthma status 3 months postpartum, and there can be an increase in symptoms at that period of time.